Thank you very much for your introduction. First of all, I'd like to summarize the previous study case that have sinus valsalva tear and ascending aortic dissection. Slide, please. Okay. The patient has eccentric calcification and NCC. It looks not so ugly because NCC sinus valsalva space is 29 millimeter. I tried to pre-ballooning, but the specialist forgot my order, so I could not do a pre-dilation because the valve area is 0.5 square centimeters. So I thought pre-ballooning is required, but she skipped it. So I have to just proceed the valve delivery. During delivery, it was very difficult to pass through this calcium. So I struggled about 1 minute. For this struggle, I guess there may be some damage in here, NCC sinus valsalva. Then after implantation, we can find such kind of dissection. Tear site is here, and it increases, it penetrates into ascending aorta. But it is NCC, thus there is no significant pericardial bleeding. That's very stable in blood pressure. There is a subtle pericardial bleeding, but it was stationary after protamine reversal. We can see there is tear site that is stented by sapien 3. Thus there is no further dissection afterwards. Thus patient stabilized, and we took CT angiography. And here is the tear site of NCC sinus valsalva. Dye is entering here, then here, and then stop. So we can see the hematoma that is not connected to the lumen. It reaches ascending aorta up to aortic arch. The patient is stable, but the extent of the dissection is a little bit broad. Thus, the surgeon decided to do emergent surgery. Thus, she is now under surgery with stable hemodynamics. The teaching point here is a kind of delivery of order. I skipped a pre-discussion meeting for this case. Just I ordered the preparation of pre-ballooning to specialist, Miss Kim, but she did not deliver my order to my team. And even though they prepared the balloon, just give me the valve without a balloon. When I talking about the panels, right. And then I recognize it is not balloon, it is just a valve. So I have to
you're distracted.
proceed the procedure. Yeah. So that such kind of struggle may be one factor to weaken the tissue of NCC sinus valsalva and easily tear.
Yeah,
like
maybe
this.
happened in the shoulder of the calcium and the normal tissue.
Yeah. It's always painful to send the patient to surgery after procedure, but I believe you made the right choice. Right choice.
Okay, I hope everything goes
But
well.
I did not perform a pre-balloon. Pre-balloon, if I perform the pre-ballooning, it may not happen. Okay.
Right.
Yes.
That is very interesting case. This is the first case of sinus valsalva tear in my 385 cases. Okay, thank you very much for your attention.
So actually, my
Then-
criteria for pre-dilation was 70 millimeter mercury, but now I need to correct down to 50. That's I learned from this case.
Pressure gradient is dependent on the LV function. Thus, even though there is very tight stenosis, LV function is not adequate. Pressure gradient is always pseudo-normal.
Okay.
Thus, I always focus on the valve area.
And
Professor
anyway,
Kim.
I will
Can you
lower
still-
my threshold.
Professor Kim, the other possibility is that you had this pigtail injection while trying to cross the valve. So if
Yeah,
the
yeah.
pigtail is not inside the sinus but in the ascending, maybe the dissection will be lessened because of this
Right.
forceful injection.
Yeah, another good point. Yeah.
Yeah.
Very good. Okay, will you start the CTO?
Usually, yeah, okay. 슬라이드를 바꾸고 싶은데. Okay, I prepared a CTO at RCA ostium. In this case, it is always impossible to do antegrade approach. So I started retrograde approach from the first through collateral. That has a very ugly two features: acutely angled entrance. Thus, it took about 30 minutes to engage wire into the acutely angled entrance, and then epicardial corkscrew channel, because septal collaterals are invisible. And I showed the actual example of braiding two-wire technique to withdraw the lost material in catheter or artery. That is very interesting teaching point. "72-year-old male, RCA total occlusion, and this is demographic profiles. Incision normal, chest X-ray normal, ejection fraction good, no abnormality of wall motion. But he has very severe reversible ischemia here, inferoseptal, and pain. Symptom and reversible ischemic area is indication for CTO intervention. We can see RCA stump CTO. We can see kind of good collaterals. Entrance is a little bit straight, small corkscrew, and a little bit difficult segment, and then easier segment. So I tried to navigate this epicardial corkscrew collateral channel. I guess it would be very difficult to engage the wire into such a kind of hostile angle and this point. But good point in this case is there is no eminent fine side branch in every turn of corkscrew. Such kind of fine branch at every turn of corkscrew is really trap. It is really impossible to advance the wire because wire always slipped into the fine side branch. In this case, such kind of fine side branch were few. Thus, I tried to retroid approach it from the first. Left always use 8 French guiding catheter. And with the backup of Carabel first, and then Sasuke, because I tried to use a Zabo technique to engage the wire in such kind of hostile morphology angle. Thus I introduced Sasuke and the hairpin, the wire.
Hyo-Soo Kim,
Hairpin, and
Hyo-Soo Kim?
first I tried to integrate the wire with Sion. Endeavor, I can engage the wire, but there is a resistance. So if I push a little bit, always wire prolapsed. Thus I tried to Zabo technique. By withdrawing this hairpin wire, I expect the tip enter acutely angled branch like this. But there is still resistance. Thus Zabo technique failed. After several maneuvers, So I did a lot of time to engage wire into acutely angled collaterals entrance. Okay, good. But until this point, it is possible. But there is resistance, so I push a little bit, then wire prolapse again. Cautiously rotating right or left. A gentle push resulted in prolapse of the wire. Using Sion and Fielder fine control.
You're
It is
using
the
Caravel
limit.
or Sasuke now? Current catheter is
Sasuke.
Sasuke, okay.
Yes. This final, my final result, last result is SO3. So this second wire is SO3. Try to engage, wire tip engage into acute angular side branch. By several trials, I was able to advance.
Always slow
I
down.
didn't know
it's
that
so
the 4-3 is
advanced.
good for the side branch selection, so it's amazing.
I changed the microcatheter to Caravel once again.
The
And this
panelists
is
can
safe zone.
ask questions or comments anytime.
Yeah. I think the takeoff of that channel is very difficult, very hostile. So Professor Kim demonstrated a very nice technique using a Sasuke. I think a Sion is a good first choice. But my second choice of wire would be a Sion black instead of Fielder FC, because FC, the tip is very easily damaged and deformed. But finally, I think SEOUL 03 is dedicated for this purpose.
Good comment.
Don't you think the Sion Black is too strong to navigate such kind of fine epicardial channel?
Well, the tip load is a bit stronger than the SEOUL 03, yes. But FC, because there's no good tip control, because the tip design is different. Sion Black, you have the Act 1 design, but Fielder FC, you don't. So I think in terms of damage risk, FC is almost the same as Sion Black. That's my personal feeling.
Dr. Kim?
Okay.
I have a question is Professor Hyo-Soo Kim. So actually in case of the RCA austere CTO, sometimes anyways we need to perform the RCA penetration puncture. So I want to know your strategy is direct crossing by the, you expect a direct crossing is retrogradely, or anyway during procedures you puncture the proximal RCA ostium. What's your expectations initially?
My hope was to introduce the wire up to the RCA ostium, because RCA ostium is wide. So I think it is easier to pass the retrograde wire into wide target of RCA ostium. But in this case, RCA ostium proximal stump was really, really hard. So even though there is wide target, I cannot introduce retro wire into antegrade guiding catheter. So I will show you later. In any way, at RCA austere stenosis, I always prefer retrograde first if a channel is available.
So technical issue here are the selection of the collateral, and second, navigation following the collateral. Lastly, I think the coming out from the right ostium is not easy, actually. Most of the wires goes into the aorta, dissecting the aorta. So
So I
three
think
technical issues here.
a CT would be very helpful in this case, because you can sometimes with the CT you can see actually where the RCA ostium is. Professor Kim, you have shown us the diagnostic. There are very two tiny upward, almost like a corner branch coming from the sinus. But sometimes there is an independent RCA takeoff. So CT would be
Yeah.
helpful.
In this case, there is a kind of definite RCA ostium with a shallow proximal stump. Because in this case, we can easily recognize the true location of RCA ostium. Okay, the
Okay, proceed.
point that we check the tip injection is just in front of the second difficult point. So I'd like to once again clarify the morphology of corkscrew, most difficult point. Just before that segment, I did a tip injection, and remember that morphology.
You are still on Sasuke, right?
and
And the
no, I changed Sasuke from Sasuke to Carabel,
Caravan.
and just right turn 3 or 4, and then left turn 3 or 4. Wait, right 3, wait, left 3, wait, to give the wire spontaneously expand and advance through lumen.
Yeah,
The
rotate
third
and
segment
wait.
was, rotate and wait, not push.
Okay.
Junior is always pushy the wire. That may erase the frictional force and spasm of the corkscrew channel.
Yeah, very nice.
Finally
technique.
fail. Minimize the frictional force is very important tip to navigate corkscrew channel. The wire easily fall off to the distal RC. It was really difficult to redirect the wire into the mid RC. Every bit, the wire prolapsed to distal RC. So it was actually difficult to advance retro or Carabel into mid RC. Then the process.
How long did it took to get there to navigate the cold collaterals? How many
Core
minutes?
collaterals, about 5 minutes, not so long in this case,
Yeah, not
because
so long, yeah.
corkscrew collaterals are better than ordinary corkscrew collateral channel.
Amazing.
But it took more than 30 minutes to engage the wire tip into
yeah.
entrance, acutely angled entrance.
After introduction
Then
of SOAR
I've-
3, actually, the navigation got much easier, but your technique is perfect.
At this point, I expect the process is over about 70%, but that was not.
Yeah.
Because there is a really hard region here,
Yeah, I believe
so
so.
it is impossible to penetrate to antegrade guiding catheter.
I think this is the most difficult part.
But good thing is, Carabel guide wire, Carabel microcatheter is just here, so we can assure the good backup support.
Currently, Gaia
But,
second.
Gaia second, and then I changed Gaia third.
Okay. How did you find the RCA ostium? The RCA guiding catheter is direct in the RCA ostium. Are you sure?
Yeah. Because in angiography, there is a kind of a morphology of RCA ostium here.
Okay.
Not blunt, just a kind of, there is a stump.
Oh,
So in this way, I always check two different rectangular angles,
Outside.
ariocaudal and ariocranial. Here, we can see, oh, there's already a good, but in other view,
right.
different.
Always the RCA ostium, there's a kind of a 90-degree angle to the proximal RCA.
So at this point, I try to poke of the proximal stump antegrade wire using Conquest Pro here.
Antegrade
It
wire
has
is
a
Conquest
really
Pro.
resistance, but finally, I puncture the proximal stump, and then I was able to advance Concast Pro here. I try to get two wires closer to each other. The direction is favorable, but a little bit distance here. In this angle, anti-wire is anterior side, retro-wire is posterior side. So I try to change the retro-wire because I use already Gaia second, third. Thus the fourth lumen is always there, so I try to make another lumen using the UB3 later time point.
So are you planning the
I
reverse
tried-
cut or just wiring going out from the RC ostium into the aorta? Which one is better, reverse cut versus just pushing the
I
wire?
think it is impossible to do reverse cut because it is very hard. So I use Astato 20 here. So I guess antegrade balloon advance would be impossible.
Okay. You try to get the wire out of the RC ostium into the aorta, right?
Yeah,
Okay.
hopefully into the anti-guiding catheter. But at least I was able to put the wire into the aorta. So I tried to use Astato 20 by try to change the lumen from the wire to get close to each other. It looks better by changing anti-wire from Concast Pro to Astato 2. And then I also changed the retro wire from Gaia to UB3 to make a new channel because about 10 or 20 minutes trial of Gaia, it did not reach true lumen.
Can I ask why did you choose Astato 20 in this kind of situation? What is the benefit of the wire?
I first tried to Concast Pro, and the Concast Pro direction is a little bit anterior side. So I tried to redirect Concast Pro to a little bit posterior side, but it did not penetrate. Thus, I use Astato 20 and make a new direction, a little bit posterior side toward retro wire.
And do you believe that the Astato 20 is in the true lumen? How can you confirm that?
There is a huge amount of intimal plaque, CTO, plaque material. I guess RCA vessel size is about 4 or 5 millimeters. Thus, it is within the plaque, I guess.
Can you
Not so
tell
difficult.
me the length of the total occlusion based on the angiography, or CT will be better? But
Probably here, from here to ostium,
yeah,
about more than 30 millimeters.
so still in the plaque, not in the true lumen, right?
Oh, plaque is true lumen, I
Right.
think so.
Plaque is plaque, not,
Not
the lumen.
media, within the media, within the
Yeah,
media.
yeah, within the vessel. Okay.
Dr. Kim,
Okay.
in this angio, so I think the gap between the two wires is not so far. So it meaning it's time to reverse cut. But previously you mentioned here you could not do the reverse cut. But so what do you think? I think in the proximal RCA's two wires really meet the plan. So if the corsairs can cross that line, so I think a reverse cut would be okay.
Yes, that is a good option, but I was confident that retro wire can easily enter into the anti-guide cut because it is very close. So we don't use another balloon at this point, but
As
it
I
took
said, it is the
time.
most difficult part of the procedure, right?
easily into the little bit deviated, but it is also RCA ostium, very close here.
So what is the
A little bit anterior
retrograde
side.
wire at this time?
UB3, the final is
UB3,
UB3.
okay.
Of course, previously I made a retrograde channel with Gaia second and third. I just try to use UB3 to make new direction channel.
Okay.
Dr. Kim, usually I changed your strategy due to the time depend. In other words, if you spend the 20 minutes or 30 minutes and then change your strategy.
Yeah, that is two options. To rapid change strategy, to make one strategy for enough time, but sometimes I rapidly change the strategy if I guess it is possibility is very low.
Okay.
But when you see just goal is there, then I focus on this process without any further change of strategy. Okay, we are near the end, so I try to change the direction of guiding catheter like this, but the wire is trapped here, so it is not so manipulable. In any way, little wire is the true RCA ostium. Thus, to save the time, I try to snare the little wire through ante-guiding catheter. Here, I use micro catheter and advanced little wire UB3. And captured it and withdraw them. Actually, I try to anchor this little wire and advance the little microcatheter, but it is impossible to release the wire trapped in snare. So I have to withdraw wire all the way.
Actually, if you capture the soft part of the wire, you can release the wire actually after capturing. If you, I'm not sure
wire
which
is,
part you
trapped.
captured, but if you capture the stiffer part, you never release it.
But I think UB3 body is not so soft. But
Okay.
anyway, UB3 was separated from the snare during externalization in the anti-guiding catheter. Here, the UB3 was retrieved, but finally, it is not in the snare, so it is trapped here.
Oh.
So
Where is the end of this wire?
I try to remove this with balloon, but balloon is slipped, not effective.
Okay, you lost the wire.
Then
during
I
the-
use
okay.
micro or macro snare, but it did not capture the wire because of collapsed status in small lumen catheter. Then I finally use biopsy forceps, but it did not wide open because of inside the narrow catheter, so it was
Lumen is
impossible.
too narrow. Huh?
Then,
Yeah.
then Dr. Hyo-Soo Kim offered me, why not to do braiding two-wire technique? Okay, I remember. So I introduced two wires.
Or you can
And-
dilate the balloon at the end of a wire and remove the guiding catheter.
It was impossible. And
To pass the balloon is impossible? The balloon over the wire. T.
Balloon was passed through the, okay, I can show you. Here's balloon,
Yeah.
slipped.
Just sleeping. The size of the balloon, what size is that? I mean,
Probably,
you pull the balloon.
2.75.
I mean the ballooning and pull out the guiding catheter.
No, Professor
Full
Kwon,
guided
you-
catheter.
It's not possible.
No, if you pull if you pull the integrate
The
guide with
guide
the
wire
wire together.
is introduced from the
Okay.
controlator side.
Okay. Yeah, we cannot remove guide.
Because
yes,
the
I
other-
understand that. Yeah.
No, because at this
So I
point, Professor
braided
Kim,
two wires and pull.
Yeah.
Professor Kim, at this moment, the other end of the UB3 is still outside of the body, is it? Or already inside the retrograde guide?
Yeah.
Maybe
Yeah. So that's
already
a
inside.
question
Here.
I'd like to ask. When you are snaring the wire, what is your next step? Because if you snare the UB3 is not 300 in length. So if you snare and you try to put it out, externalize, then the other end will be inside patient or inside the guide. You cannot do externalization with the UB3.
Yeah, UB3 length is not sufficient
Yeah,
to
you
make
cannot.
both ends outside.
No,
Thus,
no.
first I trapped. Thus,
So-
I actually successfully withdraw the UB3, and then I anchored UB3 balloon, and I introduced retrograde microcatheter into the anti-guiding catheter like
Yeah.
this. Thus, all the way microcatheter is set inside. Thus, we can withdraw UB3 even
Yes.
at the hard endpoint, because vessels are protected from the UB3 because there is all
Microcatheter.
through the
Yeah.
carabel.
Yeah. So when you snare the
Then-
UB3, actually you pull
Yeah.
you let the distal tip of the UB3 to get inside the antegrade guide, and then trap it, and then advance your retrograde microcatheter, and
Yeah.
then externalize, exchanging to
Oh, yeah.
RG3. Yeah.
Right.
Instead of
So
pulling the
UB3
UB3 all the
was
way out.
UB3 was hold here, and I introduced anchor balloon here, and anchor ballooning. Then I introduced the retro carabel into anti-guiding catheter.
Yeah.
Then all channels are protected by carabel wire. So I withdraw the UB3 here. The stiff end is within the carabel, so it did not damage the microchannel. Then I introduced RG3 from left to right, and then externalized. Then the
Very
process
complicated.
was finalized.
Okay, anyway.
Dr. Kim, so if the length of the UB3 guide wire is enough to externalization through the antegrade retrograde catheter, so I recommend the
No, UB3 cannot be externalized
Right.
in both sides.
Dr.
Okay,
Kim,
due to
yeah.
I have a comment. So before snaring the retrograde RG3, I will try the antegrade ballooning from the antegrade guiding catheter with the larger balloon and trap the RG3 and try to advance the retrograde microcatheter and change the more softer controllable wire like Shion block. So I will try the retrograde crossing to the retrograde antegrade guide wire guiding catheter.
I cannot understand exactly what you mean, but my point is I introduced UB3, retrograde UB3 into anti-guiding catheter, but it is captured by snare, so it is the kint.
Yeah. So before
it is,
before you capture the RG3, you can navigate the antegrade balloon and
No, we cannot introduce RG3 because microcatheter not inside anti-guiding catheter.
With the antegrade wire, you can navigate the antegrade balloon and capture the retrograde wire, and you can advance the retrograde carabel more proximally, and you can change the another wire.
You mean ballooning in the proximal RCA?
And capture the
Yeah, reverse core
retrograde
technique was
wire.
previously commented and mentioned. Okay. But this is the better straight way even though there is lost during the retrieval of wire through with the snare. Anyway, by holding two ends of RG3, it is easy to advance the balloon as well as to advance long, thick stent. That is beauty of RG3 externalization. By holding two ends, we can push anything. So my preference is the proximal stent first. In this case, this is RV branch. So I chose the length just before the with RCA before the RV branching site. Then I have to introduce another wire to navigate to distal RC. The retro wire is RV branching. Thus, I have to engage wire into the distal RC. This RC has a kind of dissection. Thus, I cautiously pass through the dissect segment into true distal lumen, and I withdraw the RG3 until here, RV branch, not to be captured in the another wire, distal stent. Thus, I withdraw the RG3 like here, and then I introduced stent. Ballooning first. Then I introduce the second stent from mid RC, crossover RD branch, and then distal RC, like this.
Actually, in my practice, I usually use IVUS before stenting to measure the vessel size, because frequently the vessel is diffusely diseased and it's difficult to determine the size of stent. You don't use IVUS, right?
So I don't use it because when you see IVUS image, you have to think too much things regarding the size or regarding the landing zone. It is a minor thing, but it takes time. So I think the RC size is a little bit larger than the circ, so I always introduce 3.5 or 3.0 stent.
What do you think, Dr. Zhang? You have a randomized trial yourself.
Oh, yes, I think the IVUS is essential to maintain the outcome in the long-term outcome as well. And especially in this case, the proximal RCA ostium, you don't know where the retrograde wire was out from the vessel. So
No, that is exactly it, RCA ostium. It's
looks
not
like,
blunt end.
looks like, but you don't know. You are convincing too much, angio guy. Eh?
That's it? Fight is over?
Yeah.
Okay, I'd like to ask panels, how many of you would like to do the IVUS for this patient? Raise your hands. IVUS? 4 or 5, yeah. Except 2. Okay.
Yeah.
All
We have
physicians,
Hyo-Soo Kim, we have a 3 minute.
most physicians are addicted by IVUS. IVUS is very useful in selected case,
Right,
but
like
most
CTO.
physicians routinely use IVUS.
Dr.
That
Kim,
costs a lot of money.
Dr.
Okay.
Kim, I have one question.
Yeah.
In this situation, as RCA, ostium, CTO, and you use AR1 guiding catheter. So that during the UV3 guiding catheter, pouring the UV3 guiding catheter, sometimes
UV3 wire, you
AR1
mean.
catheter is deep engaged RCA ostium, so the max produce dissection. What is your strategy to prevent RCA ostium dissection?
In this case, I use left one Amplatz guiding catheter. I don't see any significant direct severe contact of catheter tip to RCA ostium. So I don't think it is the possibility of RCA ostium dissection is high. Of course, in other case, RCA has ostium has a vulnerable plaque and CTO segment. Then we frequently observe the RCA ostium dissection. But in this case, it's very ostium, it's hard. So in this case, dissection concern was least.
Dr. Kim, I have a suggestion. If the retrograde wire is confident that it's an intraplaque and goes to the true lumen in the osteal RCA, maybe antegrade guide extension wire insertion will be more easier to externalize the wire than going out of the aorta.
Yeah, I don't know your comment, but as I mentioned before, even at status 20, it was difficult to penetrate the RCA CTO segment through antegrade approach. It is impossible to advance guide extension catheter into proximal RCA.
Yeah, I have a
After
comment.
externalization, we have very strong backup, so we can push balloon and stent. But in this case, we don't use our antegrade extension guiding catheter.
Okay, Dr. Kim, it was a very nice presentation, demonstration, and we learned a lot. And I enjoyed the fight between the panels and the moderators. Okay. It's time's up. Thank you very much.
Please check the integrity of epicardial collateral channels
Okay.
beforehand. That
It's
is very
amazing.
important.
It's almost impossible to navigate through the collaterals, and that you did it successfully. Thank you very much. So I'd like to introduce the next